responsible to produce bronchoconstriction. So when patient come to the emergency department or the problem is difficulty in breathing, so first of all, we are going to reverse that bronchoconstriction, and then ultimately we'll have to finally treat the process of inflammation. So the basic classification already we have discussed. We can say there are two main group that we'll have to use. One of the group is bronchodilators, because we are going to reverse the bronchoconstriction, that is just because of the process of inflammation. And the second group is the anti-inflammatory drugs. That means in the treatment of asthma, we have two major groups, anti-inflammatory drugs and bronchodilators, right? So in the previous lecture, already we have discussed the bronchodilators that we use generally in the acute attack of asthma. And the major group, I think you may recall, the group of first choice that can be used in the treatment of acute attack of asthma to reverse the bronchoconstriction is, anyone can tell me? Albuterol. But okay, you are right, albuterol, but short acting beta agonist. And if you further explain it, that is the short acting beta 2 agonist. This would be the complete answer, right? Short acting beta 2 agonist, that is beta 2 adrenergic agonist, right? So if the patient is not responding with this short acting beta 2 adrenergic agonist, then is there any other group that can be used to treat to reverse the bronchospasm? No, not methylxanthine. Methylxanthine is not the group of first choice or prefer anti-muscarinic. This answer is right? Anti-muscarinic drug, or that is also labeled as the anticholinergic. And in anti-muscarinic group, we have two examples of drug. One is ipratropium bromide, and the second one is the tiotropium. Now tell me, in acute attack, we are going to use the short acting, right? Short acting drug. Now tell me which anti-muscarinic drug, the name that already I have mentioned, ipratropium bromide and tiotropium. Now which one is short acting, so that can be used in the acute attack of asthma? And your answer is ipratropium. Very good. So these are the questions that we ask in the OSPE exam. Methylxanthine, there are certain specific conditions, right? Apnea in preterm baby, so we can stimulate the diaphragm. So there are some specific conditions in which we can use methylxanthine group like theophylline in emergency situation, right? So otherwise, these two major groups we use. And the third group that can also be used in the acute attack, that is the intravenous or parenteral, you can say parenteral glucocorticoids, that we will discuss in the subsequent slide, right? So already we have discussed the major side effects of beta 2 adrenergic agonist, right? Now come to the anti-inflammatory drugs, right? Okay, these are the our lecture objectives of today's lecture. Now, today we are going to discuss the role of corticosteroids in the asthma or glucocorticoids, and what are the examples of inhaled glucocorticoids. And this point also we discussed in the previous lecture, that if we say that in long-term control medication, or if we use the drug prophylactically in the treatment of asthma, the group of first choice is the glucocorticoid group. And in glucocorticoid group, which route we prefer? Inhalational route. Inhaled glucocorticoids we use. Why can't we use the oral drugs or systematic drugs as long-term control medication due to side effects, systemic side effects, right? Then describe the mechanism of action and important adverse effects of glucocorticoids and enlist the drugs other than corticosteroid used as long-term control medication in the treatment of asthma. Explain the mechanism of action of leukotriene modifiers, mast cell stabilizers, and anti-immunoglobulin E antibody. So these are our lecture objectives of today's lecture. Now, again, I am going to repeat it again that we have two problems, bronchoconstriction and inflammation. So to reverse the bronchospasm, right? And for controlling inflammation, we use anti-inflammatory drugs, right? So as anti-inflammatory drug on top, the major group is the corticosteroids, that is also labeled as glucocorticoids, right? Because corticosteroid is a broad terminology. If we say corticosteroids, that means we have glucocorticoids or mineralocorticoids, but specifically the drug that can be used as anti-inflammatory drug. So that is appropriate term that we can use in terms of corticosteroids when we are using the steroids as anti-inflammatory drug, that is glucocorticoids. So this is the main group. This is the first choice as anti-inflammatory drug, or as we use this group as long-term control medication, or when we use the drug prophylactically. The second group is the mast cell stabilizers, because when antigen antibody reaction take place, that is the rupturing of the mast cell and release of mediators like basophils, eosinophils, right? So these are the mediators responsible to produce the bronchoconstriction, and anti-immunoglobulin E antibody, right? So these are the three major groups that can be used as anti-inflammatory drug. Now, one by one, because this is the main group, this is the group of first choice regarding anti-inflammatory drugs in the treatment of asthma, right? And this point already I have explained that the most appropriate term that we should use if we use steroids as anti-inflammatory drug, that is glucocorticoids. So all the corticosteroids are potentially beneficial in severe asthma because of their toxicity. Systemic corticosteroids are used chronically only when other therapies are unsuccessful, right? The major route, this is another question. Generally, through which route we use glucocorticoids? Inhalational route, okay? Otherwise, generally we use the drug preferably by oral route because it is easy to take the drug, right? But in case of corticosteroid, we preferably use the inhalational route, because if we use the glucocorticoids orally, what will happen? There is increased chances of systemic side effects. So that is why in the treatment of asthma, when we use glucocorticoids, if anyone asks the question, through which route we generally use the glucocorticoids, your answer would be by inhalational route. And when we use inhalational route, so we must know the preparations that can be used by inhalational route, right? So why can't we use systemic glucocorticoids normally? Because of the systemic toxicity. We can use, right, when the inhaled glucocorticoids or other therapies are not showing the response, right, then we can try the systemic use of glucocorticoids. Inhaled corticosteroids have become common first-line therapy if for individuals with moderate to severe asthma, right? This point already we have discussed. Important intravenous corticosteroids for status asthmaticus. Status asthmaticus means life-threatening condition, severe asthma, right? That should be treated promptly, right? Quickly, right? Include prednisolone, the active metabolite of prednisone. This is one of the intravenous preparation that can be used in emergency situation, and hydrocortisone. So this you must know, right? So what are the parental preparation that can be used in emergency situation? Your answer would be prednisolone and hydrocortisone. So this slide is very much important, right? So what are the examples of glucocorticoids that can be used by inhalational route, or we can say what are the examples of inhaled glucocorticoids? So out of these 1, 2, 3, 4, 5, 6, 6 examples at least, you must know the 3 or 4 examples, right? Beclomethasone, triamcinolone, budesonide, flunisolide, fluticasone, mometasone. So these are the examples of inhaled glucocorticoids. And intravenous glucocorticoids, we have prednisolone and hydrocortisone. Mechanism of action, you know, already we have discussed, if you try to recall, already we have discussed the NSAID in one of the previous module, non-steroidal anti-inflammatory drug. You know, the arachidonic acid pathway. Can anyone tell me how arachidonic acid is produced? How arachidonic acid is produced? Arachidonic acid is produced from the phospholipid, and okay, is acted upon. Okay, this is under the influence of enzyme phospholipase A2 enzyme, right, which act on phospholipid, and it is responsible to produce 20 carbon unsaturated fatty acids like arachidonic acid. So arachidonic acid is produced, and basically this arachidonic acid, why we are discussing in so much detail about this arachidonic acid? Because this is the arachidonic acid that will ultimately enter into 2 pathways which are playing an important role in the process of inflammation, right? So there are 2 pathways, lipoxygenase pathway and cyclooxygenase pathway, that we will show you the slide in the next slide. So just the mechanism of action. Okay, yes, you are right, answer is right. Mechanism of action is attenuating prostaglandin and leukotriene synthesis via inhibition of phospholipase A2 reaction, right? And it is also inhibiting the immune response, and very important, they increase sympathomimetics and decrease mucus production. When we say sympathomimetics, that means if a patient is taking either short-acting beta-2 agonist or long-acting beta-2 agonist along with glucocorticoids, so basically this glucocorticoids, they are going to enhance the responsiveness of sympathomimetic drug. So this is another very important point of this glucocorticoids, use of glucocorticoids. Now this is the diagram. You can see the phospholipid under the influence of phospholipase A2 enzyme converted into arachidonic acid, and arachidonic acid will enter into 2 pathways. Either with the help of cyclooxygenase enzyme, it will enter into the cyclooxygenase pathway and ultimately responsible to produce synthesis of different prostaglandins, right? And the second pathway, when there is availability or action of lipoxygenase enzyme on arachidonic acid, it will enter into lipoxygenase pathway, and this lipoxygenase pathway is responsible to produce very important series of compound, that is the leukotrienes, right? And the key point, what we must know at this level and related to this topic, that leukotrienes are supposed to be the most powerful bronchoconstricting agent, right? So there are some prostaglandins which are also responsible to produce bronchoconstriction. But if we compare, okay, which pathway is basically responsible to produce bronchoconstriction more, your answer would be leukotrienes. That is from the lipoxygenase pathway. So another very important conceptual point. Sometimes someone says that if a patient is taking aspirin, you know, aspirin is one of the example of NSAID, right? So in some patient having a history of asthma, if we introduce aspirin into that patient or prescribe, or if they are going to take the aspirin, right? So this will increases the chances of asthma attack in that patient. Why? The answer is because when that patient is taking aspirin, we are going to block the cyclooxygenase pathway. You know, let me explain it. Suppose arachidonic acid, when arachidonic acid is synthesized, either 50% it will enter into lipoxygenase pathway, 50% will enter into cyclooxygenase pathway. But if we block cyclooxygenase pathway, you know, the diversion, totally arachidonic acid diverted towards lipoxygenase pathway, the maximum production of leukotrienes will produce. So this is one of the reason of a patient having a history of asthma, the attack of asthma is going to be exacerbate or increases. Episode of asthma attack is going to increase. This is due to this phenomena if a patient is taking aspirin or NSAIDs as well, right? Use of inhaled glucocorticoids is recommended for the treatment of asthma prophylactically. So this point already we have discussed. In an acute attack, we usually prefer the bronchodilators, and the group already we have discussed. When we use the drug prophylactically or in long-term control medication, inhaled glucocorticoid group is supposed to be the group of first choice. So this is again this point. Use of inhaled glucocorticoids is recommended for the treatment of asthma prophylactically rather than to reverse an acute attack. When the patient is stabilized, now we are going to prescribe the inhaled glucocorticoids to avoid the future attack of asthma. The most common adverse effects, this is one of the questions that is asked commonly in the exam. The most common adverse effects of inhaled glucocorticoids are hoarseness and oral candidiasis. But we can avoid these local side effects if what we are going to advise to our patient who is on inhaled glucocorticoids after taking the dose, if you will wash your mouth properly, we can avoid these problems, hoarseness and oral candidiasis, right? So these are the common side effects, but they can be avoided, right? How these side effects can be avoided? If we advise our patient to, after using inhaled glucocorticoids, after taking his or her dose, if they are going to wash their mouth properly, right, we can avoid these problems, right? The most serious adverse effects are adrenal suppression and osteoporosis. It occurs when systemic treatment is required for more than 2 weeks, as in severe refractory asthma, right? And you know, very interesting point, this adrenal suppression serious side effect, but not common. And we can avoid this adrenal suppression problem by taper off the dose, by tapering the dose. What does it mean, this tapering of the dose? Suppose if a patient is taking glucocorticoids for a long time, so if we gradually, we are not going to abrupt the therapy suddenly we are not going to stop the therapy, right? So normally what happens, if pain is subsided, we are going to stop taking painkillers, or there are some specific times for the antibiotic course like 5 days, 7 days, or 14 days. In case of especially if you are using the drug systematically, especially orally, if a patient is taking glucocorticoids orally and that therapy is of more than 2 weeks, so it is recommended don't stop the therapy abruptly. Tapering of the dose or taper of the dose. So suppose if a patient is taking 2 plus 2 tablets of glucocorticoids, right? So when you are going to taper off the dose, so it can be if a patient is taking suppose 6 tablets a day, you can convert into 4 tablets, then 2 tablets, and gradually stop the therapy. Because of their systemic adverse effects, oral glucocorticoids are usually reserved for patients with severe persistent asthma. Now this is the point, rapid discontinuation of systemic corticosteroids after long-term use may precipitate adrenal insufficiency, right? So regular use of inhaled steroids does cause mild growth retardation in children. So this is another point. That is why the recommendation of using leukotriene receptor antagonists, right, in children. But if leukotriene receptor antagonists are not showing the response, so ultimately we'll have to use the inhaled glucocorticoids. But this is one of the point that it may affect the growth of the children. But these children eventually reach full predicted adult stature, but during the therapy it looks retarded, right? So in that situation, we can use the leukotriene receptor antagonist. So nowadays, to avoid the problem, especially in children, we first try the leukotriene receptor antagonist profile as a prophylactic drug. But if that child is not responding with leukotriene receptor antagonist, so ultimately we'll have to use the powerful inhaled glucocorticoids, which is very much effective. The second group is the mast cell stabilizers, and we have two examples, cromolyn and nidocromyl. Cromolyn sodium or disodium chromoglycate and nidocromyl are usually insoluble chemicals, so that even massive doses given orally or by aerosol result in minimal systemic blood levels. They are given by aerosol for asthma. Mechanism of action: decrease the release of mediators such as leukotrienes and histamine from mast cells. The drugs have no bronchodilator action but can prevent bronchoconstriction, right? Because they are not absorbed from the site of administration, cromolyn and nidocromyl have only local effects. When administered orally, cromolyn has some efficacy in preventing food allergy. Similar action have been demonstrated after local application in the conjunctiva and the nasopharynx for allergic immunoglobulin E mediated reactions in these tissues. So clinically, very interesting point I wanted to share with you, that in the treatment of asthma, we are not using this group, right, in our community. But you can find if a patient having the allergic conjunctivitis or allergic eye, so one of the preparation that is available for this allergic conjunctivitis, that is of cromolyn sodium, right? Cromolyn and nidocromyl may cause cough and irritation of the airway when given by aerosols. So this is one of the local side effect. Now this is another very important group, one of the group that is very important or major group as far as the long-term control medication is concerned or prophylactic treatment of asthma is concerned, that is the inhaled glucocorticoids. Now this is the second group. After that, inhaled glucocorticoids, leukotriene modifiers. Why we have used this term leukotriene modifiers? Because we have two groups of drug related to this leukotriene. One of the drug, and already we have discussed, that lipoxygenase enzyme, when it's going to act on arachidonic acid, it will be converted into leukotrienes. So one of the phenomena or one of the mechanism could be to stop the formation of leukotrienes if we are going to inhibit the activity of lipooxygenase. So lipooxygenase enzyme activity is inhibited, so there will be no conversion of arachidonic acid into leukotrienes, right? Second option could be, second mechanism could be whenever leukotrienes they are going to, whenever or wherever they are produced, and ultimately for its activity it has to bind with its specific binding sites, that is called leukotriene receptors. So after binding they are going to produce its activity. So this is one of the most appropriate mechanism. If we block the binding sites, right? If we block the binding sites, so if leukotrienes produce anywhere in the body, not only in the respiratory tissues, right? Anywhere in the body, if it's produced ultimately through blood, if it will enter into the lung tissue and bind with the leukotriene receptor, it can produce the bronchoconstriction. So if you block the receptor, so it will produce the appropriate result. It will show the appropriate or most beneficial result as compared if we just block the lipoxygenase enzyme, right? So these drugs interfere with the synthesis or the action of leukotrienes. Although their value has been established, they are not as effective as corticosteroids in severe asthma, right? So already this point already I have told you again and again, the powerful group is supposed to be the inhaled glucocorticoids, right? So the leukotriene antagonists have effect on both bronchoconstriction and inflammation, but are used only for prophylaxis. So this is very interesting point. In some books, you will find that leukotriene modifiers having dual activity. Dual activity. Dual activity means not only produces anti-inflammatory activity, but it also has the ability to relaxes the bronchial smooth muscle. So that is why it is, this group is labeled as showing the dual activity, right? But if this group has the capability to produce the bronchodilation, so can be used in the acute attack? No, its use is reserved only for prophylactic treatment or long-term control medication, because onset of action is slower, right? So it will take time. So the leukotriene antagonists have effects on both bronchoconstriction, this point you must remember, and inflammation, but are used only for prophylaxis. This leukotriene receptor blocker, this is important group, zafirlukast and montelukast. So these are the two preparations which are available. But again, another very interesting point, that which one? Okay, we have two examples, zafirlukast, montelukast. These two preparations, they are going to block the leukotriene receptor. So leukotriene receptor blocker. Which one is being used clinically nowadays, commonly? Your answer is montelukast. Very good. Montelukast is being used commonly. So zafirlukast and montelukast are antagonists at the leukotriene E4 specific leukotriene receptors. Leukotriene E4 receptor is also blocked. These drugs are orally active and have been shown to be effective in preventing exercise, antigen, and aspirin-induced bronchospasm. These drugs are recommended as an alternative. Please note this point. These drugs are recommended as an alternative to medium dose inhaled glucocorticoids, right? So they are not recommended for acute episodes of asthma. Right, so this point already we have discussed, that preferred group is the inhaled glucocorticoids. So if some suppose patients, they are showing the dramatic even dramatic effects on not tolerating even inhaled glucocorticoids. And suppose in children, if we suspecting that if we continue this inhaled glucocorticoids, it can affect its growth. So we can try as alternative this leukotriene receptor antagonist. But again, I am repeating, the powerful group is still the inhaled glucocorticoids, right? So this is the diagram. You can see that there is a receptor. So this drug, it's going to bind with this receptor, and so leukotrienes, they are unable to bind with this receptor. Toxicity is generally low, but adverse effects of zafirlukast include headache and raised liver enzymes, right? Elevated liver enzymes. Now you can understand that why montelukast is being used commonly. Why can't zafirlukast is being used? Because of the side effects, or even because of the multiple dosing, right? In case of montelukast, just once OD dose is sufficient. Just once OD dose is sufficient. But if a patient is taking zafirlukast, multiple dosing is required, and at the same time will have to face the adverse effects like headache and raised liver enzyme. So that is why we prefer to use the montelukast. The most beneficial effect is the least dosing. Just once in a day dose would be sufficient. Lipo-oxygenase inhibitor, this already we have discussed, because in the beginning the slide was leukotriene modifier. So one of the group is going to block the leukotriene receptor, and the second group is to inhibit the lipo-oxygenase enzyme, which is responsible to inhibit the synthesis of leukotrienes by inhibiting the conversion of arachidonic acid into leukotrienes. So example is lipo-oxygenase inhibitor. Only one example, that is the Xylitol, is an orally active drug that selectively inhibit 5-lipo-oxygenase enzyme, which is a key enzyme in the conversion of arachidonic acid to leukotrienes. This drug is effective in preventing both exercise and antigen-induced bronchospasm. It is also effective against aspirin allergy. The bronchospasm that results from ingestion of aspirin by individuals who apparently, this point already we have discussed, who apparently divert all icosanoid production to leukotrienes when the cyclooxygenase pathway is blocked. Xylitol is administered orally, usually 4 times per day. So again, the problem is because nowadays, patients, they are reluctant to take the multiple dosing. They prefer to use the single dose usually, right? So this is one of the important point that if we have least dosing available preparation, so we must prescribe those preparation, right? So this is one of the reasons that Xylitol is not being used commonly, number one. And number two, if we compare the effectiveness, right, that is more with leukotriene receptor antagonist than lipo-oxygenase enzyme inhibitor. Diagram. So lipo-oxygenase enzyme activity is inhibited by Xylitol, so there will be no production of different lipotrienes, which are responsible to produce the bronchoconstriction. Toxicity of Xylitol includes occasional elevation of liver enzymes, and this drug is therefore less popular than the receptor blocker. Now the last group, anti-immunoglobulin E antibody. When antigen-antibody reaction take place, right? So there is rupture of mast cells, right? So because when the first exposure takes place, there is no problem, right? Suppose there is a foreign substance enter our body, our immune system is going to be activated. Beta cells, they are responsible to produce the antibodies against that foreign substance, right? So on first exposure, there is no reaction, there is no bronchoconstriction, right? Why? Because on the first exposure, our immune system is going to be activated and it's going to produce the antibodies against that foreign substance, against that antigen, right? So after exposure, now immunoglobulin E is present in our body. Before the first exposure, there was no antibodies, but due to that foreign substance, immune system is going to be activated and they produce antibodies against that allergen. Now, antibodies are present in our body, for example, after that first exposure. Now, on the second exposure, what will happen? So, this antibody, which is now present, will bind, will attach with the mast cell, and antigen is going to attach with this antibody. So antigen antibody reaction take place and there is rupturing of mast cells. So in that, what will happen? There is release of inflammatory mediators responsible to produce the bronchoconstriction. So one of the important example against that, this immunoglobulin E, to prevent this antigen antibody reaction, that is omalizumab. So at least from the exam point of view, you just know the name of this drug, monoclonal antibody omalizumab, blocking the binding of immunoglobulin E to mast cells and basophils and other cells associated with the allergic response. Omalizumab is approved for treatment of asthma in patients over 12 years old and who are refractory to inhaled glucocorticoids, right? The drug is administered by a subcutaneous injection every 2 to 4 weeks. Now, this is the diagram. So, you know, on the first exposure that already we have discussed that antibodies, immunoglobulin E. So, what does the term refractory means here? Refractory means the response, patient is not going to show the response. Again, even against the most powerful group, that is the inhaled glucocorticoids. And in some patient, okay, now this is a sequence. We usually prefer the inhaled glucocorticoids, but patient is not responding. Okay, we can use the oral glucocorticoids, but increased chances of toxicity, side effects. And in some patients, there are some problems in which we cannot use the oral glucocorticoids. So in that situation, what can we do? And the alternative is leukotriene, suppose leukotriene receptor antagonist, and even patient is not responding. When all the conventional treatment, they are fail, right? Showing no response. So that term is called the refractory to other treatment, showing the resistance to other treatment. Patient is not responding. So that is why in that situation, sometimes you'll have to use the drug that may show the some serious side effect, but result is good, right? So in that situation, we can try, right? So this is the meaning of refractory. So on first exposure, there is no problem. This point already we have discussed, because on the first exposure, our immune system is going to be activated. B cells are responsible to produce immunoglobulin E antibodies. They are going to attach with mast cell. On the second exposure, now that allergen or antigen or foreign substance, they are going to bind with this immunoglobulin E. Antigen antibody reaction will take place, the rupturing of the mast cells. So this omalizumab binds to free immunoglobulin E, decreasing cell-bound immunoglobulin E, decreases expression of high affinity receptors on which immunoglobulin E bind, decreases mediator release, decrease allergic inflammation, prevents exacerbation of asthma, and reduces symptoms. Now, this slide is very important, right? So, classification, clinically, we can classify mild intermittent asthma, mild persistent asthma, moderate persistent, or severe persistent, right? So, bronchoconstrictive episodes, right? less than 2 attacks per week, right? If the patient come to you and says that, okay, I have an attack of bronchoconstriction. So if that is less than 2 per week and result of peak flow or spirometry is normal, so no long-term control medication is required. This is important. Mild intermittent, what does it means? And the bronchoconstrictive episode is less than 2 per week, no long-term control medication is required. We can put that patient on quick relief medication, that is the short-acting beta-2 agonist. We can say, okay, when there is such episode, you just take short-acting beta-2 adrenergic agonist inhaler, right? Mild persistent, more than 2 per week. Long-term control medication now will have to start after using quick relief medication, right? Low dose inhaled glucocorticoids. So we start the therapy with low dose inhaled glucocorticoids. If the clinically, if we are going to label as moderate persistent, that means daily bronchoconstrictive episodes. 60 to 80% of the normal value of the spirometry, right? So low to medium dose inhaled glucocorticoids that already that patient is taking, now will are going to add a long acting beta 2 agonist, right? So we'll have to give the combination low to medium dose inhaled glucocorticoids plus a long acting beta 2 agonist. So in the presence of, and very interesting point, only long acting beta 2 agonists wouldn't be effective. This is very interesting point. Long acting beta 2 agonist will show the maximum effect, maximum efficacy in the presence of inhaled glucocorticoids, right? So low to medium dose of inhaled glucocorticoids plus a long acting beta 2 agonist. Can anyone tell me the examples of long acting beta 2 agonists that already we have discussed in the previous lecture? At least two examples of long acting beta 2 agonists. Here is the answer, and one is solmetrol and the second one is formoterol, right? Okay. And severe persistent, that is the continuous, that is the very critical condition, right? High dose inhaled glucocorticoids and a long acting beta 2 agonist. And if the patient is in emergency and that is the status asthmatic, that patient is unable to take the breath, so we can use the intravenous glucocorticoids, and we have two important examples of intravenous glucocorticoids that can be used in emergency situation. Can you recall the examples of those two parenteral glucocorticoids that can be used in emergency situation in the status asthmaticus? That is the prednisolone and hydrocortisone. Very good, excellent. Right now, this is all about the treatment of asthma. Now I'm quickly revising the important points overall collectively, right? So what happens in OSPE exam? Okay, what are the short acting beta 2 agonist examples like albuterol, salbutamol, terbutaline? So these are the examples. Next question is, what is the mechanism of action of beta 2 adrenergic agonist, right? So most of the patients, students, right, they reply the answer by saying just beta 2 adrenergic agonists, they are showing they are going to relaxes the bronchial smooth muscle. Okay, this is the right answer, but the complete answer is sometimes examiner asks, okay, how? So this also we have discussed by stimulating the adenyl cyclase enzyme, and it will increases the production of cyclic AMP, and basically increased level of cyclic AMP is responsible to produce, relaxes the bronchial smooth muscle. So this is the complete answer, right? So alternative drug, if the, because one of the problem, if a patient is taking beta 2 adrenergic agonist, sometimes they are not going to show the response, and this condition is called tolerance, right? So if patient is not responding, so alternative we can use antimuscarinic drug. This point already we have discussed in the beginning of the lecture, and the short acting is ipratropium bromide and long acting is tiotropium. Okay, the side effects of beta 2 adrenergic agonist, especially if you are taking using inhaler or inhale beta 2 adrenergic agonist, the two major problem. Can anyone recall the important side effects of beta 2 adrenergic agonist? Tolerance, okay, tolerance, okay, skeletal muscle tremor and tachycardia. And fortunately in children, tachycardia is not common, but tachycardia is common in adults, right? So these are the common side effects that is asked in the exam. Then methylxanthine, right? So methylxanthine nowadays, methylxanthine is not being used. In the past, methylxanthine supposed to be the drug of choice as prophylactic drug, right? But because this group having low therapeutic index, right? That means the difference between the effective dose and lethal dose is low. So if a patient is on methylxanthine theophylline drug prophylactically or long-term control medication, so we'll have to continuously monitoring the blood level of this drug, right? So this is very difficult practically, right? Practically, it's very difficult if a patient is taking drug and at the same time that patient has to monitor his or her blood level. So that is why nowadays we replace this methylxanthine group with leukotriene receptor antagonist. This is important point. But from the exam point of view, methylxanthine mechanism of action is oftenly asked, not only in BCQs but also in a Viva exam. There are two possible mechanism of action of methylxanthine. Can anyone repeat? Okay, here is the answer. One of the answer is it inhibits phosphodiesterase enzyme. So what will happen? Inhibition of phosphodiesterase enzyme will prevent the degradation or breakdown of adenyl cyclase enzyme. Breakdown of cyclic AMP. So when there is no breakdown of cyclic AMP, the level of cyclic AMP will remain high. That is the key for the smooth muscle relaxation, right? And the second mechanism of action is it inhibits the adenosine receptors, right? It inhibits the adenosine receptors. Very good, right? So this is the question that can be asked in the BCQ related to this concept, right? So the glucocorticoids or mast cell stabilizers or leukotriene modifiers that already we have discussed today. So this is all about the treatment of asthma, and already we have discussed again and again the key points or important points from the exam point of view, right? So I think we go to the last slide, and that is very important slide. And thank you. So why does osteoporosis happen when glucocorticoid therapy? No, no. If a patient is taking chronically, right, chronically, so that is why, you know, when we say suddenly stop the therapy, I just mentioned the adrenal suppression. Osteoporosis develop if a patient is taking therapy for a prolonged period of time, right? So osteoporosis doesn't develop if you are going to suddenly stop the therapy, right? Any more questions? So we are going to leave. Okay, thank you so much. Thank you so much.